Welcome everybody to the International Telemedicine Grand Round. This meeting has been happening for 12 years now, happening weekly. I'd like to disclose that this is an educational meeting. We should avoid any political or non-educational comments as per request of the Pan American Trauma Society. Every day around the globe, you have civilians get injuries with military weaponry. Can be in a conflict in a favela in Brazil, or in a jungle in South America, or in Africa, or anywhere in the globe. Usually civilians can have injuries, and quickly the civilian response centers and the hospitals and the surgeons, the trauma centers can be overwhelmed. So it's our pleasure to have here today Colonel Mark Buzzelli, from the Army Trauma Training Department, detachment here at the Ryder Trauma Center. I'm going to be sharing his expertise, his knowledge. We're going to be talking today about civilian trauma assistance and combat casualty care, considerations and preparation. Mark, thank you very much for willing to talk to.
Yeah, thank you for inviting me today. Hello, everyone. Again, Mark Buzzelli. I'm by way of a little additional introduction. A U.S. Army trauma surgeon on active duty, but assigned here by my good fortune to the University of Miami and the Ryder Trauma Center here at Jackson Health System. The job that I do here actually involves trauma training in a pre-deployment fashion for U.S. Army forward surgical teams prior to their deployment. But the talk today is born out of a lot of my own personal deployment experience, including this past summer where I found myself at HKIA, Kabul, Afghanistan during those last 2 weeks of August. And so I certainly want to open the floor throughout the presentation to additional comments and points of view. I know this panel that's dialing in has a great deal of expertise in trauma care. And the thing I'm going to try to do is transition or bridge, maybe what we normally do in the civilian world to what might need to occur in more of a military setting. So next slide, please. Why this matters now, I thought this was important to start with, because this was really, I think, the underlying reason behind Dr. Martos inviting me to speak with some urgency. The migration of refugees out of Ukraine is rapidly becoming a humanitarian crisis for its neighboring countries. So Poland, Slovakia, Hungary, Romania, and Moldova at this point are seeing, I think I heard on the news today that Poland reached the 1 million refugee mark into Poland alone, with the other countries with several thousand going into those other countries. So already they have this population that's flooding across their borders. And if this conflict continues the way it seems to be going, it might not be long before some actual military casualties start flooding across these borders as well, in kind of similar fashion. So next slide. I do apologize if this is not the deepest dive into the trauma experience of those Eastern European countries, but just some quick scan of the internet. The countries in question here, so Poland, Slovakia, Hungary, Romania, Moldova, none of them make the top 20 list for firearm deaths and violence. So my assumption is that they may have very robust trauma systems, but not necessarily with high rates of gun violence as part of their practice. The other slide, a map, is of terrorist activities with at least one death going all the way back to 1970. And as you will see, there are very, very few dots throughout those Eastern European countries. So again, an area where I would say military grade violence is extremely uncommon. And so these trauma systems may get called into action for things that they do not normally do. Next slide. So we'll jump right in. If this conflict starts to cross international borders, or at least those wounded in the conflict start to cross international borders, they should expect to see combat trauma. The pictures I have here are all from my recent trip to Afghanistan. The wounds that you're seeing is something that was a bit new to me. There's a young boy there with a right thigh wound. There's an adult male with a large sucking chest wound. Those were all from non-lethal munitions, so flashbang grenades being used in attempts to disperse crowds, but when those go off in contact with your skin, they cause these type of wounds. So we were seeing some pretty horrific wounds from non-lethal munitions such as flashbang grenades. You also get some medical mysteries. So the picture there in the center, the reason why we have a CT scan, if you can see at the front end of the forehead, there is a skull fracture and penetration, but that was not obvious from the skin. It really looked like a very small hematoma with just a little punctate wound. And the patient came in with vital signs. We could not figure out why this fellow had a GCS of 3 until we scanned him. And so, again, the, I guess, challenge of ballistic injuries is somewhat unique. And so I did want to use this slide to highlight some of the uniqueness of military style trauma. So much more severe wounds. Certainly the gunshot wounds are more of a high velocity style, so rifle style high velocity with much more significant tissue destruction, a much higher need for aggressive tissue washout, the amount of burns that we see, the blast injury patterns, and now, of course, from the news, you're seeing some of the munitions that the Russians may be using, the idea that the patients may come with penetrating wounds over large areas of their body where it's difficult sometimes to tell where to start. When there's injuries, penetrating injuries to the face, neck, chest, abdomen, and pelvis, plus all of the extremities, it's sometimes hard to decipher where exactly to begin, where is the most immediate life-threatening injury. And so, again, I don't have a lecture that's going to give all the answers to that. There's just too many possibilities, but it's just a shift in the way that maybe a civilian trauma center that is primarily used to seeing blunt injury only or blunt injury primarily needs to think about their trauma patients. Next slide. So I do want to mention triage, but I am here with a colleague of mine, Lieutenant Commander Brendan O'Brien is one of our trauma fellows here at Miami and is a U.S. Navy physician. So he has a separate few slides that'll be at the end of my presentation to discuss NATO triage, arguably one of the most important things in these trauma responses, but not the focus of my talk. Brendan's going to talk about that at the end. So next slide. So we'll start with the actual trauma teams at these locations. I think it starts with realizing that you might be underprepared, and so the best thing to do is to begin with some rehearsals and to rehearse with realism. The training program that I direct here in Miami really strives for that realism. It's amazing how often, at least within my military experience, the medical casualty response might be part of an exercise, but it's very much minimalized. It's done in a way that does not set realistic expectations for complexity, certainly not for time. They're just kind of breezed through, and you talk about a trauma laparotomy, you don't necessarily perform one. And so I feel like at every step in the patient care process, we often miss the mark in terms of really accurate, realistic trauma casualty rehearsals. And so even down to patient movement within a facility, I found that incredibly complicating while in Kabul this summer. Once we truly were, in a real mass cow response on 26 August from the bombing at the gate, it was very difficult to move patients anywhere. To clear my trauma bay meant getting a patient into the ICU, but once the ICU was full, there was really nowhere to go. And so that patient movement piece and where you're going to offload patients is sometimes as important to rehearse as actual patient care. I did want to comment, and this is more of an ATLS perception I have. I've had the good fortune of working with many NATO allies, primarily from Western Europe. And I do notice that there are some stylistic differences. Not that one is necessarily better than the other, but the more Western European model is a very methodical, precise approach to ATLS that I believe sometimes sacrifices speed. And in a situation where you have many patients lining up outside your hospital, I do think you need to adjust to more of a speed-based response rather than precise. The idea being that you're really just there to identify immediate and potentially life-threatening injuries, and the fine details can be sorted out later. I'm not sure if how the others on the call feel their trauma responses normally go. Here in Miami, we are not so regimented. I would say it's very much in the style of Miami that we certainly follow ATLS, but our trauma responses are not this exercise in precision like a military guy like myself might necessarily expect, but they are, in my mind, still very effective. I don't know how the rest of the group it feels they kind of orchestrate their trauma responses.
Mark, I agree with you 100%. The first thing is life and limb, and then we can find the metacarpal fracture and the grade 1, adrenal laceration later on.
Yeah, understood. Yeah, just moving on. The other thought is that you really do need to have some flexibility in your response, and particularly for mass cows. The temptation a lot of times in some of my military experience is that if we are not very busy, that when you start becoming busy, that everybody wants to be part of the action, right? Everybody wants to show up, everyone wants to be there, no one wants to leave. And yet you start to realize very quickly that that is not sustainable in terms of work and rest, and that you really do need to take a hard look at your team and divide them up appropriately in a way that allows sustained operations over many hours and many days, with folks rotating off cycle to get a little bit of rest. I also feel that a lot of mass cow responses are of kind of one flavor. It's the, everybody shows up for, major mass cows, but we see these, what I would maybe term as more of a surgical mass cow, where you don't necessarily need an entire hospital response, but you definitely need more of a surgeon/operative response to increase your operating room throughput. And so to realize that may need to be in place as military casualties start flowing over the border of these countries. So next slide. So with any trauma resuscitation, we are absolutely dependent upon good use of blood transfusion. While surgery might be our practice, it's truly blood is, I would say, equal parts of that life-saving solution. And so a civilian center that is not used to seeing a lot of blood need may need to rapidly increase that supply. So things like blood drives, although maybe not orchestrated entirely by a hospital system, I think certainly could be requested by a hospital system. Certainly the public is aware of what's going on, and often you get very good response from the public in terms of feeling like they could do something to help the cause, and donating blood is one of those things. With the current situation that we're talking about, I think there also needs to be some thought as to how blood is distributed or potentially redistributed. The large population centers of these other European countries might not be near the border regions. And so if a redirection of blood needs to get closer to where these countries expect to see more patients, I think that's a critical piece and something that needs to be part of their logistics planning, if not already. One thing we've done within the U.S. military is, with our whole blood use in particular, is to move away from type-specific blood. Although it still might be used at times, the simplification of going to a low titer O whole blood distribution program, I think is something that greatly simplifies our transfusions, patient safety, and our overall logistics. Now, how easily a civilian entity maybe wraps their head around converting to this, might be more challenging than even I realize. I assume, again, here in the U.S., there would be state laws and regulations that might hinder this type of effort. But I do feel like in extreme situations, there might be some room to push the envelope a little bit in terms of what is allowed within the blood banking and distribution community. And I don't know if anyone has any thoughts on that, as how to pivot kind of a countrywide blood program to really focus on low titer O whole blood. Does anyone share?
Hey, Mark.
I just wondered about the use of FFP. Has that been an effective resuscitation fluid?
I lost you at the beginning, Dr. Crocker.
I was just asking, I thought when they first used FFP, they found that it was a pretty good resuscitation fluid in place of, in many cases, could replace if whole blood wasn't available.
It could. It certainly would be a valuable adjunct. But again, in terms of maybe a prioritized list of what we should be giving to hemorrhaging trauma patients, whole blood would be ideal, because they're losing whole blood. And so while FFP by itself might be a reasonable contingency plan, whole blood would really be the ideal resuscitative fluid. I think Dr. Namias, did you?
Yeah, I think in places, if you're talking about now surging up for a lot of mass casualty in places that, and in hospitals that don't normally do a high volume of trauma, they probably don't have an existing whole blood program, but it'd be pretty easy to educate people to get on board with one-to-one if they're not already. So I think like for short-term ramp up is to educate on one-to-one if they don't have whole blood in place already. That would be my approach.
Very good. Thank you for that. Next slide, please. I did want to take a minute and talk a little bit about radiology. It is extremely valuable to us, but yet I feel that we almost never, in my experience, really have much of a radiology presence in MassCal and kind of disaster response planning. And I think my experience from Afghanistan, that was to our detriment. We had a wonderful radiologist. We even had, we had portable X-ray capability that was quite good. We even had a old CT scanner that was reasonable. But they, I guess, just as a profession, don't necessarily the switch doesn't flip and put them into more of a mass cow mode when maybe it should. And so I feel like this is a potential area for improvement across all of our mass cow responses. My Afghanistan experience, a lot of people got long bone x-rays. And after, operating for 12 plus hours on the immediately life-threatening things, myself and my orthopedic colleagues then went about to try to figure out who had long bone fractures that needed to be immediately addressed. And, talked to the radiologist and we're told, well, it's all in my reports. And so at that point, we lost our cool for just a second. They really do need to think of these critical injuries and long bone fractures in a way that is not, just kind of fire and forget in their medical report. They need a way of tracking that and quickly getting that information to us so that we can go into that next phase of trauma management, particularly with long bone fractures. And so I think some of that too also involves, willingness to come out of their reading room and do some time with us at the bedside. And another example I could give is the complexity of keeping track of who is who, and sometimes not necessarily matching the right patient up with the right images. And so having them come to the bedside sometimes helps solve those problems. And so we were operating on a patient that I was told by a very brief report likely had a ureter injury. And so we had explored this young girl's right ureter, which is what we had told was injured, and really weren't seeing anything. Of course, then, called the radiologist, hey, could you come in here and talk to us? What is this finding that you're seeing? And of course, once we got him there and we said, look, we're not seeing anything, the story quickly was, well, no, it was a concern. It wasn't a definitive injury. I'm glad you're exploring it, but I didn't necessarily call it a definitive injury. And so just some of the lost in translation things that occur in the fog of a mass cal event. Next slide. I think another critical thing, and this is a picture from the old TV show MASH, showing multiple simultaneous operating room tables in the same room, is rethinking your space to be much more useful than maybe it is currently. And so at HCAIA, we had fairly large operating rooms. And so while there were only 2 of them, they easily could handle more than 1 patient at a time. And so we had rehearsed that ahead of time and then actually put it into use where we were operating 2 patients per room simultaneously. And I found that to be extremely beneficial. The patient throughput, of course, that's kind of obvious, right? You're doubling your OR space. But really for the collaborative effort within complex injuries, we only had 1 vascular surgeon with us, and he was able to bounce from table to table in a way that I think was much more efficient because he was in the room listening to what we were saying the whole time. Same thing with our orthopedic colleagues. I cannot stress that enough, that when all of us are working together, it's sometimes nice to be within the same space, that we can hear each other, collaborate with each other, ask for assistance if needed, and get the best possible patient care amongst the group of us that might be operating during a mass cal. The plan for space allocation, I think those should be kind of worked. I do think the ORs tend to be the highest value real estate and some of the biggest rate limiting step. And so I think about those first, but you can plan outward then within the rest of your hospital footprint as to other places where reasonable patient care can be conducted with things that are lesser than actual operations. So certainly resuscitative capacity does not always need, a beautiful modern trauma bay, places in the hallway, places outside, all kind of different spots can be utilized. But I think the key is that you plan where you're going to fight those fights and you stage those areas with some additional equipment so they can actually be functional. No one can do anything in the hallway if the hallway is empty. But if there is, whether it's by backpack or with shelving, if areas are made more kind of friendly and functional for trauma resuscitative ATLS care, a lot of areas in the hospitals can become patient care areas. Next slide. So I would say, whereas triage might be the most critical part of the decision making, patient identification and documentation is probably the most frustrating part of all this. The way that different hospitals, especially if they are not used to working in sync with each other, everyone seems to come up with a different plan as to how to identify trauma patients when they're first arriving and are not identifiable by their actual name or numbers. Again, I do not have the perfect answer to this. So I'm more than happy to have anyone else from the group kind of comment on, again, this becomes not just a coordination piece within your hospital, it might be a coordination piece within your larger area where patients might be migrating from, smaller trauma hospitals to larger, trauma hospitals, and you have to keep track of them as the same name. And we have certainly seen this in the military where, we name them one thing in Kabul. When they get transferred to Landstuhl in Germany, they get another trauma name. And then by the time they reach the US, they're properly identified, and now they are identified by their actual name. And so you have these three separate medical records that eventually need to be merged, but it's often very tricky. And the larger the numbers, the harder it is to make sure you're being precise in your patient identification. So I'll pause there if anyone has any thoughts on patient identification. I've certainly seen some things with wristbands and barcodes and things like that. But again, the heavier we rely on modern technology, sometimes the more apt we are to pitfalls where they can fail if the technology fails. For Nick and Carl, I'm thinking like if we had to transfer our patients, say, into the memorial system up at Broward, like what kind of a nightmare that might be.
Yeah, it would be a nightmare. Initially after 9/11, we were talking about being able to identify patients across hospitals by having a website, photographs, coordinators to help. But you run into all the problems with HIPAA and privacy, and I'm sure that anyone who hasn't been there for 20 plus years forgot that we even had tried to implement that system. So I don't have an answer for this at all.
Yeah, even now when we get a patient from Broward, they just come with this unintelligible medical record that really doesn't help us much.
So something we might not be able to solve in the short term, but at least if institutions in these countries in Eastern Europe, at least something to think about, to maybe start trying to come up with some contingency plan in the short term, but maybe a worthwhile project in kind of in terms of a national or international trauma system, some way of making ourselves a little more compatible, at least at the patient identification level.
Dr. Buzzelli, I think Dr. Antrak raised his hand.
Yes, please.
Yeah, so we're here in Baghdad, what used to be the combat support hospital during Operation Iraqi Freedom, and is now the diplomatic hospital. There's also the combat hospital next door, which came back during Operation Inherent Resolve in 2014. Anyway, in our preparations for mass casualty incidents, we have these trauma folders, each one of which has a pack of charting like what you have there, although yours look very, very good and very adaptable. And I was wondering if you could maybe make a copy of that available in the chat so we can adapt ours to more conform with what you have. But each packet has a patient number, an identifier, on the paperwork and also a wristband with the same identifier. So you don't need any special equipment. Every patient's accounted for, has a number on a wristband that's low tech. And once they're, we have their proper identity, then the name gets put together with that tracking number, basically. And I believe there is a barcode, but we don't really need a barcode. We just need to have some way of keeping track of records with the patient, so we know who's who.
Yeah, no, agree. And I can share this. The next couple slides go into some resources that our Joint Trauma System has through the DoD, but it is open source, and so I feel like it's important to put that out. So I'll get to that in just a second. I do want to highlight the other form. So there's a casualty card, which is kind of TCCC field care that should be tagged to our patients coming in from point of injury. But our Joint Trauma System has kind of 2 levels of documentation, and there's kind of a full form, which many of us might recall is like that old trauma trifold, multiple pages, lots of details. But they have pared it down to a Moscow form that's a little simplified, a lot of check boxes, makes things a bit easier to keep track of. But yet, if you're not familiar with the form, it's still a bit cumbersome until you get used to it. And so having some way of both accurately but rapidly being able to put information onto some form of medical record, I think is important. But at the end of the day, we certainly have had seen many times where we've adapted and just you end up writing that information kind of directly on the patient, right? So a good felt tip marking pen and the patient's IO-band dressing end up communicating a lot of information in written form kind of on the patient's body. So next slide. So these are those resources, sir. And so if you're not familiar, the Joint Trauma System has an app called the Deployed Medicine app, and that red square is the symbol for it. It is available open source on app stores, but it is kind of your one-stop shop for all of the products that the Joint Trauma System has available. And so it's quite easy to access, and just kind of highlighting some of the things that they have with some very recent updates to both our tactical combat casualty care and our tactical evaluation or en route combat casualty care. And then of course there is a whole list of clinical practice guidelines related to surgical care. The forms, the documentation forms that they would like us to use and prefer us to use are also available for download through this app. Next slide. The corollary to the app is the actual JTS website. So I also wanted to share that as well. Sometimes a little easier to use on your desktop when you don't have to rely on your phone and your app. But the CPG have kind of highlighted there is relatively new, and I think a great starting point. It is a very broad overview of military combat casualty care in more austere locations. And so although these countries where refugees are flowing into now would certainly not be considered austere conditions or places normally, the overwhelming numbers is going to make them feel somewhat austere just because of the resource utilization being overwhelmed. The CPGs, I think, are an incredible resource for any of us. I feel that in my military time, the ones that are, kind of in my wheelhouse of trauma surgery are nice to review every once in a while, but hopefully my day-to-day practice is keeping me up to date in those realms. But it's really the things that you don't see normally, or that when you are the only medical asset in a certain area, you're going to get asked to deal with things that are not necessarily within your typical civilian subspecialty. And so we have particular CPGs in terms of dealing with neurosurgical emergencies for the general surgeon when you do not have that neurosurgery colleague available. And it really is quite impressive how much we can do when forced to, and kind of if we're the best neurosurgeon that patient is ever going to see, it's in my mind a better option for them than not intervening at all. There's all kind of other CPGs though as well, everything from snake envenomations, which again I don't see a lot of in my day-to-day practice, but I have downrange, and it's a great CPG to kind of quickly pull up and give you quick guidance on how to treat appropriately. So I find them very valuable for the kind of odd or unusual things that you might be forced to see. And then for those that don't practice trauma care regularly, the more broad trauma ones are great primers if you need to kind of refresh on penetrating trauma. And I don't know if Colonel Gross, if you're still on the line, I don't know if you have any comments regarding your feelings on the overall JTS, the CPGs, and kind of their ease of access and utility.
Yes, thanks, Mark. Yeah, the CPGs have served as each individual CPG serves as an individual chapter in the textbook of deployed trauma surgery. And it's proved to be a very valuable asset, and proved to ensure that we have at least some degree of standardization of care along our continuum. It's been described that our trauma system in the military has been one hospital on 3 continents. And certainly that's been the experience as we've been in the Central Asia area over these past several years. And you can imagine it's very important that the individuals at the ROL2s, the damage control resuscitative surgical sites, have a approach which would be consistent with what is done at the ROL3s, which are definitive care sites in theater, as well as that of our ROL4s, that is the first evacuation site out of theater, but before the casualty gets back to the States. So the CPGs have been able to get everyone on the same page and ensure the same approaches are conducted, and it really helps minimize that variation in care. There's a study published by Joe DeBose, gosh, this is 12, 13 years ago, specifically looking at the outcomes for penetrating head injuries, severe penetrating head injuries, and remarkably, our combat casualties, when compared to a group of civilian casualties, had just as good outcomes, even though we did not have the density of neurosurgeons. And the authors surmise that a good part of that may be because we are actually compliant with our clinical practice guidelines. So the clinical practice guidelines have been a real linchpin of our deployed trauma system. But not only is it valuable to guide care now, each of the CPGs has a performance improvement section, so that our joint trauma system performance improvement section actually assesses the compliance with the CPGs and helps also determine, track the follow-up. So having the performance improvement metrics built into the clinical practice guidelines helps us determine, helps the joint trauma system determine where the gaps are, and helps decide if perhaps the material wasn't available in here, or perhaps more training needs to be done. But agree, Mark, that the CPGs are a huge part of our success in these past 20 years. Now, the challenge for the current war, our colleagues in the Ukraine, and certainly there will be quite a bit of variation in care, and overlaying some degree of system in that environment will be a true challenge. So, but thank you.
Thank you, sir. Appreciate that. Next slide, please. So I'll wind down here in the next few slides, but I did want to kind of get beyond just the nuts and bolts of trauma care and maybe tell a few things that are going to help shape the rest of this story when you are being overwhelmed by not just traumas, but an overall humanitarian crisis. So next slide, please. I think any of these locations need to be concerned and have some plans in place for both their own security and crowd control. There is not much, in terms of the, I guess, thought process of that kind of mob mentality of a group of individuals who are both very scared and very frustrated. You see some of the crowd control going on outside of HKIA, but then inside, when we were dealing more with our refugee population, there had been some small shops and things throughout the air base that just got ransacked. If they were not if they were not being guarded, there was just no stopping these crowds from kind of going in and trying to make the best of a bad situation. And so I do feel like any medical facility is at risk. Certainly there are, a thought in most folks' minds that is a safe place, place where they can likely get most of their needs met. And so I think it's something that a large crowd could quickly overwhelm unless there's already some plan for safety and security. Next slide. Certainly, in our civilian world, we might not necessarily, as military folks, be the only people managing refugees. We certainly have other civilian organizations that help, but I feel like it's an area with so much overlap that we have certainly done some of this in our own military experience, and I would expect that if you are medical personnel, there is going to be overlap with these refugee operations. So, helping to feed and shelter these folks, providing some type of clothing and preventing exposure, but then really some good medical, public health thought into the sanitation. That rapidly becomes another potential public health issue at these refugee camps. In addition, the need for even just basic medications. Most of these people who have fled, maybe they did travel with some medication, but certainly not enough to last them for a very long time. And so many routine diseases that are easily treatable, diabetes is kind of the obvious example, now are, spiraling out of control because they don't have access to their medications. And so there almost needs to be a concerted pharmacy type effort around these refugee camps. So even if they're not traumatically injured patients, there's still quite a bit of medical need and medical assistance that likely will need to go on at these locations. Next slide. So the next thing here is the idea of also having to deal with families and children. Often in the confusion, children can get separated, or they actually are orphaned and are there without a true adult to help take care of them. And so we found ourselves in Afghanistan basically running a hospital, a refugee camp, and an orphanage all in one location. And so just the task of supervising these young children was something we all had to share in, but it was certainly a time constraint in terms of what we could do each day. You're also going to need to think of not just beyond regular adult food, but the idea of having formula or even pumped breast milk if available, certainly diapers. and even, you know, toys and games. And so things to keep these children occupied, because they, you know, despite the tragedy of what's going on around them, they often remain quite typical children throughout the whole thing. And so just, you know, sharing with you the baby I have in my arms there is that baby that's going over the wall. Had the good fortune to care for her for a little bit on one particular day while in Afghanistan. Next slide. And so the last comment in terms of you know, thinking through, you know, what's going on in Eastern Europe as maybe a system of care is thinking through where your medical presence is going to be most needed and most useful. So the idea of at border crossings and refugee camps, certainly those locations are going to need additional personnel, additional equipment, and really to be effective, need some of that planning and logistics worked out ahead of time. If true military casualties do start flowing over the border, I think these countries are going to have to organize casualty collection points. They will need good communication systems and some plan for patient movement into these various civilian hospitals that might be able to take care of the traumatically injured. But there has to be kind of that initial starting point where you begin to organize what's flowing over your border into some manageable construct. And so I believe that's my last slide. And so that this idea of a casualty collection point, I think, should lead nicely into Brendan's talk about triage, but just I think go one slide ahead. Did you advance the slide? I'm sorry, I did have one additional slide. I think the last thing that I would like to mention is the kind of idea and maybe preparation, mental preparation for providers on the ground that are going to be dealing with this. This concept of moral injury, maybe a little different than PTSD, because maybe our lives are not necessarily at risk, but kind of seeing the horrors of war and not being able to intervene, or at least not intervene ideally, I think takes a toll on many of us. It is a you know, sometimes an internalized pain or problem. But this particular book I'd come across is something that I think addresses this issue head on. And the quote comes from the original MASH movie, that there are 2 rules of war. Rule number 1 is that young men die, and rule number 2 is that doctors can't change rule number 1. And so I'll leave you with that thought as kind of my last comment on you know, being a medical provider in a less than ideal conditions with you know, many military casualties surrounding you. Certainly, I'm standing by if there's any further questions or comments as we transition to Brendan's.
Mark, Kirby Gross here. Nice talk. Very good to see you, and some very valuable points. You made a comment earlier about noticing the difference between perhaps our European colleagues and some of the U.S. folks as a resuscitation is carried out. I think a good part of that has to do with recognition. You know, certainly you and your colleagues at Miami are true experts in the resuscitation of a critically ill patient, and it's certainly something which you do every day. Day in and day out. You get certainly the pattern recognition just comes second nature to you. And perhaps our colleagues who may not have that robust experience, that's why it seems to be a more stepwise evaluation of the trauma patient. Over.
I would certainly agree. It's just, I've seen somewhere it's almost like there's someone reading from a script and you cannot move on to step 2 until you have completed step 1. And it's kind of coming from, you know, one person is truly that trauma lead, but they almost prevent things from occurring in parallel, and it really becomes this very linear ATLS model that I've seen some more junior folks try to implement. Over.
Now, there may be a value for that in certainly perhaps our folks getting familiar with trauma to have to ensure they don't miss anything. But I need in patients where we know every minute counts, that stepwise approach can be counterproductive. Over.
Yeah, I believe Dr. Namias was saying this not very long ago. I recall that LD 50 of time in the trauma bay is about 10 minutes. All right, I'm going to turn it over to Lieutenant Commander Brendan O'Brien. I'll let him introduce himself. Thanks, everyone.
Good morning or good afternoon, everybody. I'm Brendan O'Brien. I'm one of the second-year fellows here at Ryder, and I had the pleasure of working with Dr. Martos and Colonel Gross, representing and actually Colonel Gross in the past life. But we'll just briefly go over some of the important aspects of triage in a mass health scenario. So next slide, please. The idea of triage is that you're dedicating finite resources to improve the chances of a positive outcome for individual patients. And the 3 T's that we really kind of need to take into account is, time. So how much time is required to initiate each of these interventions, and how long will that intervention itself take? Thinking about who is actually on the ground as a medical provider, what is their expertise? So do we have a group of general surgeons who maybe patients with bad cranial injuries, would not be the best theater for them, or do we have a broad group of trauma providers that can provide good care? And then treatment. So how resource intensive is the treatment that is required? Next slide, please. Who should be performing these the triage? As Colonel Buzzelli alluded to in his last slide, ideally there's a single inflow for these patients as they're coming in, and then they're met by a triage officer. A lot of the handbooks talk about, there should be an experienced surgeon, but that's not always possible. You're taking away a pretty valuable resource in order to do a non-surgical thing. So, and I'd be interested to hear from the group what thoughts they have. So the next best person would be some sort of experienced medical provider, such as an emergency physician. In the Navy, our doctrine has always been that the triage officer will be the dental officer on the ship, which is kind of a silly idea if you sit back and think about it, because they really don't know much about penetrating trauma or abdominal trauma, thoracic trauma. So, if there are folks in the group that have, in their systems have identified triage officers that maybe aren't ER physicians or surgeons, that'd be interesting to hear. Next slide.
Hey, Brendan, if we're talking about civilian centers now, right? So these aren't going to, for what's going on now, we're not going to have these small teams with such limited resource, right? They'll be going to a civilian hospital. And, I only had really one opportunity to be involved in a real sort of mass casualty situation, a bombing. And that was back in Atlanta at the Olympic bombing. And in fact, the single most senior surgeon took it upon himself to do the triage until the last patient had to go to the OR, and then he took the last one. So I think that might actually be possible if the civilian hospitals will now be taking, a surge of injured patients.
Dr. Namias, can I jump in? How is that senior surgeon really definitively aware that that was the last patient, though? Was there?
Well, in a civilian system, he knew what was incoming from EMS, right? So it wasn't going to be some surprise military thing. It was warnings from EMS from the scene. So he was able to know that, and waited. He took the last one himself. I was actually the most junior surgeon on the scene, so he sent me up with the first one, and then the rest kept going up until all the surgeons were utilized, and the vascular surgeons did general surgery, and the OB surgeons did general surgery, and then the very last one he took.
Thank you, sir. Next slide, please. So now we can get into the triage category. So your immediate or your priority one patient are those that require, essentially immediate attention. So from hitting the door time 0 to maybe 120 minutes or 2 hours out. And these injuries include, but obviously not limited to, airway obstructions, tension pneumos, uncontrolled hemorrhage, penetrating injuries to the torso, neck, and pelvis with signs of shock. So this is really the life, limb, and eyesight of trauma care. So these are the patients that when they come in, the cards that Dr. Buzzelli had, there's a red sticker or some sort of red tape that's on this patient to mark them that they are proceeding directly from the triage area to the operating room. Next slide, please. Your delayed or your yellows, the priority 2s, who delaying treatment, we're generally not in danger of the life, limb, or eyesight. They still may require some sort of resuscitation with blood products or fluids, or some sort of dressing at the scene just to staunch bleeding. But so these are your blunt or penetrating injuries without shock, the long bone fractures like Dr. Buzzelli was talking about, soft tissue injuries without significant bleeding, people who don't have airway compromise. So these are the folks that can, once they hit the door, they can be shuffled off to a separate area just to receive some stabilizing treatments and wait for the OR. Next slide, please. Then you have your minimals or your priority 3s, and these are the injuries that really can either be treated by the patient themselves or just with minimal assistance. These are the folks that tend to arrive probably first to the medical treatment facilities because they can come on foot. They don't require ambulance. So these are the folks that, as Dr. Buzzelli was talking about, can really overwhelm access points. And so it's important to have some sort of system there to be able to sort these patients. And then, if really in a true pinch and you're running out of hands, these are people that potentially could provide additional manpower to care for some of the wounded. Next slide. And then, of course, you have your expectants. These are the patients whose treatment will be too resource intensive, and potentially treating them could reduce the chances of survivor for other salvageable patients. So these are patients that arrive without signs of life or without vital signs, transcranial gunshot wounds with a GCS-3, open pelvic injuries with uncontrolled bleeding, high percentage burns, and then the higher spinal cord injuries. Next slide. Then the final is your deceased patients that arrive dead. These are labeled with a black sticker. And the only really kind of pearl here is that there should be an area for these patients to be placed so that they are out of direct sight for those that are still coming in. Next slide. And then special considerations, certainly, hopefully the current conflict or the current war in Ukraine will not be escalated to this, but decon area is something that should be set up ahead of time, because patients that come in and are wounded but are contaminated with biological or chemical agents, they can still get some pre-hospital care, but they really they must be decontaminated before entering the treatment facility. And then in the rare case of a retained unexploded ordnance, these are patients that should be taken and separated from all other patients in an isolated area and then treated last. Next slide, please. So to tack on with what Colonel Buzzelli said earlier, obviously the JTS CPGs, the website's down there. Another couple good resources, I think. Another open source, the Emergency War Surgery book can be found there. There's a lot of good pearls in there. And then, just something that either training hospital staff or, so training your respiratory techs or your radiology techs, or, just kind of increase manpower. In the case of a MassCal, the American College of Surgeons has a course called Stop the Bleed, which I believe you can actually take virtually, and teaches really those non-trauma oriented on how to stop life-threatening hemorrhage in a very effective manner. Thank you for your time.
Any questions or comments for Dr. Buzzelli, Dr. Brandon? Okay, I would like to say thank you very much for Buzzelli, my friend Dr. Buzzelli. Brandon, Brian, thank you very much, sir. We at the Pan-American Society University of Miami are really supportive, all heroes, paramedics, first responders, physicians, nurses, surgeons, everybody, every healthcare professional that works with civilian with traumatic injuries around the globe. These kind of injuries happen everywhere. 10 years ago, you remember Dr. William Sanchez from Colombia describing injuries from the war in jungle in Colombia. Unfortunately, this kind of situation happened everywhere in the globe. And you have right now an emergency situation in Europe, in Ukraine. So I hope this lecture can help everybody involved in civilian care after combat kind of injuries to be prepared and at the end to save lives. Thank you very much.